It's 9 o'clock in Finland and it's 4 o'clock in Australia. And this is a quick and completely not planned Q&A session for group call. Again, guys, very good morning to you, and thank you for the amazing feedback we received from you after the first episode of our first international medical podcast hosted by 3 paramedics from different countries. We are so humbled by all the feedback we received. Thank you, and hopefully we will rectify all the technical problems that we faced in the first episode. So watch this space. Why we're here today? We're here today because apart from amazing feedback from you guys, we received a few questions. You were really curious about a few things regarding posterior strokes and not only. And as we want to be what's the word I'm looking for, as interactive as we can, we decided to quickly assemble this session, Q&A session, to answer those questions. Please say hello, guys, to Teemu and Harrison. Good morning, guys, or good afternoon, Harrison.
Good afternoon.
Now, a couple of questions for you. First one from Helga, Germany. Is Harrison free?
No, I assume romantically. And not in terms of my calendar is free at the moment. Being on leave. But no, unfortunately, romantically.
Okay.
Sorry.
Jokes aside. First one, how common is posterior stroke in your countries? And let me quickly answer this question firstly. So, ladies and gents, I've got a research here conducted by Dr. Melwick from National Hospital for Neurology and Neurosurgery in London. And unfortunately, that's 2014, data from 2014. That's the latest data I could get now. So posterior stroke, ladies and gents, it's around 20-25% of all ischemic strokes in the UK. So it's a huge number, 20-25%. How it looks like in Finland, Mr. Silva?
Yeah, I think the occurrence is pretty much the same. It's 25%. In terms of like actual numbers, I could not find any recent statistics. But yeah, stroke in general in Northern Europe is pretty much the same. So I would probably err on the side of caution and say it's like really close to what Alex said as well in terms of like numbers, obviously adjusting for population.
Perfect, thank you. Let's now quickly jump over the ocean to Australia, Mr. Steed.
Yeah, so like Teemu, I wasn't able to find any actual statistics on the breakdown specifically in Australia for posterior strokes to anterior strokes. When we look at the incidence of stroke, what we have in Australia, it's about 56,000 per year, obviously give or take each year. And then about 12,000 deaths as a result of that. So when we extrapolate from that 55,000 or so, we're looking at probably around 3,000 to 4,000-ish roughly that would be posterior. 25% sort of rating there. But yeah, no actual statistics in terms of the breakdown, particularly in Australia. So
cool. Let me stay in Australia for a few more moments. The next question, and I believe it's a question to Harrison, as that was his subject, his topic, and he prepared the whole anatomy and physiology background for this episode. Harrison, why the symptoms are so unspecific?
Yeah, so when we look at where stroke symptoms come from and how they occur, it's due to what region of the brain is affected. And the brain's a really, really complex structure with very sort of different regions across its surface. So with anterior strokes, some of them are a little bit more typical, but with the posterior strokes and the structures involved there, the symptoms that they cause have a broader range of differentials, and that's why I think it's sort of more non-specific. So if you were more, the reason that we did the podcast was to focus more on posterior strokes, and I think as more education comes out, they'll become more specific because we're more aware of them. But I think it's more so it's lack of education around posterior strokes, but also a greater range of differentials for these symptoms. So we'll talk a little bit about the actual structures again that are involved with the posterior circulation and what their role is. So the brainstem is basically the major control center for your autonomic nervous system. So that's regulating things like your heart rate, your breathing, digestion, vomiting, all those sorts of things. So if the brainstem is severely affected, it can really knock you about. But any sort of minor infarct on that can affect your autonomic nervous system. Your cerebellum runs your coordination, movement, and proprioception. And for those that aren't aware of the term proprioception, it's basically your body interpreting where its parts are in relation to itself and in relation to space. So sort of when you close your eyes and you know where your hands are without seeing where they are, essentially. So, and the cerebellum also does some other cognitive functions, like cognitive reasoning, attention, all that sort of stuff, which are a little bit hard to sort of test for. Then the thalamus is also in the posterior circulation, so that's your relaying of like sensory and motor information. The auditory and vestibular structures, which is sort of part that we focus on with that as well. So your auditory, so your hearing, and vestibular is your balance and your detection of movement. So a little bit different to proprioception, where you're detecting where your body is and how your body is moving. This is sort of detecting sort of speed and direction and things like that. And that's where the vertigo comes from, that sort of sensation of movement when there isn't any movement. It's an insult to that vestibular area that's causing a faulty signal, essentially. And then also the visual cortex. So that's the processing of the visual information, so facial recognition, things like that, colors, and also depth perception. So we spoke about last week the finger to nose test. So that's going to assess for a couple of different things that we just spoke about. So your coordination and your movement and your proprioception, but also that depth perception as well. So that's why that test is pretty useful for identifying posterior stroke. So and another thing as well, so as I mentioned, your posterior stroke has a broader range of differentials. And that's why I believe that's where a lot of sort of non-specificity comes from. So when you look at, say, if you have a patient presenting with like a sudden onset of dizziness and nausea, that in itself can be caused by all sorts of different things. And if someone just says, "Oh, I'm feeling all of a sudden felt really dizzy and I feel sick because of it," it's also really easy for a paramedic and clinician to sometimes discount that as something else. Oh, just a vague or just hypertension, or you probably just ate something wrong. And it's also the patients themselves can sometimes not adequately explain how they're feeling. So they might just say, "I'm feeling dizzy," but really getting the patient to explain this vertigo, which is a little bit different to just feeling sort of lightheaded and a bit off. That's where this sort of comes from as well. And we spoke about last week patients having a much greater chance of being misdiagnosed with posterior stroke. So your odds ratio of approximately four times more likely if they're presenting with nausea, because it's so associated with many other different presentations. So yeah, so look, in short, the non-specificity I think will improve as we do more podcasts like this and people learn about these symptoms and learn to associate them better with stroke. But yeah, it's all pretty much associated with where the region in the brain is affected.
Perfect, thank you, mate. Now the next question is actually to me. So why Alex referred us to NICE guidelines, it wasn't broadly explained. Yeah, that's true, guys. Actually, I said about NICE guidelines, and we didn't, or I didn't elaborate on that. The reason why I said about NICE guidelines in terms of Great Britain is that recommendation 1.4.7 in NICE guidelines says consider thrombectomy together with intravenous thrombolysis between 6 to 24 hours of symptom onset to people who have acute ischemic stroke. And that's apart from one more sentence which says the outcomes for people who have a posterior circulation stroke is usually poor. This is partially due to difficulty in diagnosing the stroke due to no focal presentation. Again, that's basically summarize what Harrison said. But in terms of the UK, that's the recommendation: thrombectomy and IV thrombolysis between 6 and 24 hours of symptom onset. That's NICE guidelines, and hence why I mentioned it when we discussed our country's approach. Okay, let me jump to Finland, Mr. Silver. What is the T window in Finland, please?
So yeah, I was looking at the different studies done on it. Obviously, Finland follows the like the worldwide consensus on stuff like this. The most recent one is from 2020. It was published in Duodecim magazine in Finland, done by Stribian, Isokangas, and Lindsberg, and they were discussing the T windows and the treatment of stroke in general, like thrombolysis and thrombectomy. And they basically said it's 4.5 to 9 hours, depending on the situation. That's like the optimal window, but it can extend up to 48 hours from symptom onset. How much depends entirely on the clinician, on the neurologist or the neurosurgeon treating the patient. And they will like based on all of like imaging, CT scans, MRI, and obviously CT angiogram to figure out how much damage is there, what sort of areas are actually ischemic and which are like obviously like fully dead, and see whether it's worth it to do it or not. And especially from what I understood with thrombectomy, they quite often do it quite late, and it can be done quite late, whereas like the original thrombolysis time window of 4 to 5 hours is extended when going to thrombectomy. But yeah, that's what I found. So 4.5 to 9 hours, but up to 48 hours depending on the situation, which is especially good for like our wake stroke kind of patients who would otherwise really suffer from these T windows being quite short, because they might be sleeping through the symptoms and then wake up, and there would be no way to know when they started originally, like back in the day, they didn't really get any treatment and suffer because of it. So it's better now and going towards a more better place all the time, which is good.
Perfect, thank you, matey. Let's stay in Finland. The next question, which basically you answered a bit in a second ago. How does the stroke pathway look like in Finland from taking the call to the discharge from the hospital, please?
So yeah, I'm gonna assume that we're discussing a situation where everything is handled perfectly, which is obviously not the case in real world. So the call taker taking the call will recognize the symptoms correctly. The paramedics going to the scene will recognize everything. And from that point of view, obviously, if something breaks along the way, it will cause delays and possibly problems for the patient during the treatment. So the call takers that are taking the calls are trained for 2 years by the rescue services or like their school, and they are given the guidelines from the Ministry of Health in Finland on how they triage patients over the phone. So if they get like a hint that there might be stroke symptoms, they will get an ambulance on scene as an emergency call, obviously. The ambulance will get the code 706, which tells us that it's a possible stroke, which will obviously direct our thinking towards like the face, arm, speech kind of neurological tests, and those will be done quite promptly from what we've seen in studies in Finland on paramedics assessing the strokes. After the stroke has been like recognized by the paramedics, obviously the same treatment as everywhere else, nothing much to do on scene, but optimize A, B, C, D, E, make sure the patient is not hypoglycemic so that we're not missing it, like I said last week. And obviously manage their blood pressure and heart rate to optimize the blood flow in the brain. So then we come to a crossroads, basically. So Finland is a big country. Some of the areas are much more populated in the south, and obviously there's much more hospitals and higher level hospitals, more like in the south than in the northern parts. So I don't know that well in terms of the northern parts, like how the pathway goes, but in the south, or like the southern part where I work, I would pre-alert the hospital receiving. It would be like a central hospital, like semi-big, like the second highest level basically. And they are capable of CTs, MRIs, and most likely a CT angiogram as well. And they can thrombolize, but they can't do a thrombectomy. So we take the patient there as a pre-alert. They will go straight to the CT scanning from our stretcher, and then the hospital will take over. The clinician treating there, usually a neurologist or like an acute specialist doctor, they will decide on whether they will do a thrombolysis, or they might consult a university hospital, which if there are like a few in the southern part is level 3 or 4. And if the neurologist or the neurosurgeon in the university hospital feels that they might be a candidate for thrombectomy, then they will actually choose tenecteplase instead of alteplase for the thrombolysis and organize for a quick transport to the thrombectomy. And then obviously the ambulance crews will take them, or they'll take the patient. But recently, there has been basically like a bypass procedure in place. So in my area in Päijät-Häme, which is like an hour north from the capital, there are regions on the western parts of our area that are so close to Tampere and Tampere University Hospital, which is capable of thrombectomy, that based on this scoring, Finnish pre-hospital stroke scale, we as ambulance crews will actually consult the neurologist or the neurosurgeon in the university hospital. They might ask us to actually bypass the central hospital in our area, proceed straight to the university hospital, and take the patient straight to thrombectomy. And that's also where the helicopter might come in that I was discussing last week, that the helicopter might actually take the patient if it's faster. So the Finnish pre-hospital stroke scale quickly is just basically face, arms, speech, and also conjugated eye deviation. So other things are 1 point, eye deviation is 4 points. If the patient scores 5, they are basically a candidate, and then the neurologist will decide whether it will happen or not. But then sometimes, even if they don't score on the stroke scale high enough, I might still consult and let the neurologist decide based on our findings, and obviously the patient as well. Like if they are like we usually talk about taxpayers, so fully functional adults with like long life expectancy and good basic functions, doing everything themselves, they are more likely to actually be diverted straight to the thrombectomy side. Once the treatment's been done, the patient will obviously recover in the hospital. If it was in a different area, they might transport it back to their own area. So basically from the university hospital, they might come back to the central hospital to recover. And then the rest is obviously physiotherapy, speech therapy, whatever is needed for the patient to regain as much control of all of their functions as possible to give them a good quality of life in the future.
Yeah, so I'll start off by explaining in Australia, the majority of our ambulances are what I've heard referred to overseas as van ambulances. So it doesn't seem to be as common in, for example, London and throughout America, but in Australia, pretty much all the state-based ambulance services, for the most part, are using a Mercedes-Benz Sprinter ambulance as a van style, as opposed to the pod style that I see used in a lot of other countries, which is a bit more cozy, we'll say. And myself being about 6'1", 6'2", the headroom isn't great in those smaller platforms. So the mobile stroke unit that's used here in Melbourne, in Australia, is an extended wheelbase version of the Mercedes Sprinter, and it's a cab chassis. So rather than being the van, it's just the front section, and then has the pod on the back, which again is similar in sort of shape and dimensions to what you see overseas in probably your standard ambulances, but just a little bit longer to accommodate the extra crew. And also obviously the CT scanner and some of the extra equipment. So in terms of what it looks like, it's a very similar shape. It's not like a bus or anything like that, anything too crazy. And what I'll do is I've got a link to a Vimeo video from when the mobile stroke ambulance here in Victoria was announced. We'll put that in the description in the video, so you guys can watch that. That sort of gives you a bit of a tour of the both the outside and the inside of the MSU. In terms of the cost, I wasn't able to sort of get exact costing, because the one that we're running here is in a trial phase over 5 years. I believe the trial's got another 2, maybe 3 years to go in terms of what's deemed as the trial period. But they, over those 5 years, they projected it to cost $8 million Australian, which for those in America listening is 5.9 million US and 4.2 million British pound. I'm not going to go through and translate every currency out there. You can do your maths on there. So yeah, 8 million Australian dollars over 5 years. The actual CT scanner they use, that was $500,000 alone. So that was 360 American and 260, again roughly, in pound. There was a paper that was released last year. Now, unfortunately, in all the databases I've got access to, I don't have access to the full text for this one. There's the International Journal of Stroke by Kim et al., entitled "The Economic Evaluation of the Melbourne Mobile Stroke Unit." So I've only got the abstract here, so I can't really elaborate too much on the cost involved there. But they found that per disability adjusted life year that was added by this mobile stroke unit, it was approximately where is it here? It's about $31,000 extra cost in having the mobile stroke unit compared to your standard care. So when you look at the DOEs that we mentioned last week in that paper, it was about 21 years roughly for thrombolysis, and just shy of 25 years for clot retrieval. So for each of those years, approximately $31,000 Australian, which works out to about 23,000 American and 16.5 pound. So that's your sort of rough cost in terms of a looking at it from a disability adjusted life year point of view. Some other costing I found. So UC Health in Ohio, in America, they also have a mobile stroke unit. So they listed their startup costs as $1 million US, which is 1.4 Australian, 720,000 pounds. So that was their startup cost, and they estimated the annual cost of running to be $500,000 American, so 680,000 Australian dollars, 360,000 British pound. A lot of numbers there, a lot of costings. So, and I'm not exactly sure on what like their exact numbers on how many they've been able to treat with that, and I couldn't find a paper from them similar to one I found earlier that was breaking it down in terms of life years that have been saved or improved as a result of the treatment. So yeah, look, all in all, they are fairly costly when you look at just the raw numbers, the raw data. But when you take into account the potential, as Teemu was mentioning previously, if these patients are taxpayers, if they have a lot to still contribute to society and the economy, the money spent in preventing their disability or their mortality can obviously go back to the economy in the form of an employer, form of a taxpayer. So potentially in the long run can actually save money. So yeah, that's a brief rundown of the MSUs. And as I mentioned, I'll put that video in the notes, so you can have a look at that and actually see the platform.
Perfect, thank you guys. I will just remind our viewers and listeners, www.groupcall.uk. You will find all the recordings there. You will find also additional information in the description to the video. Now, I just received a text from one of my friends. By the way, hello nurse, thank you for watching. And he said that I wasn't my microphone was on mute when I was asking the question to Harrison. Well, it's a bit too late to repeat the question because you had Harrison's answer. It was the question on mobile stroke units. Guys, thank you so much for joining in. I hope we are still working on the sound. Hopefully there is no echo now when we all are on the screen. Let me know in the comments below, guys, how did you like it? If you have any questions, also put it in the comment section, or just go to www.groupcall.uk and there is a form you can complete and ask the question. Hopefully, if everything will go up to the plan, we will see you guys in a week from now, 23rd of September, and then we will discuss approach to COVID vaccination amongst medics. So stay tuned. Harrison, Teemu, thank you so much, guys. All the best. My name is Alex Hepner, and this was Group Call.